In today's lesson, we are going to discuss medication administration for pre-hospital professionals. Module 2 will cover the different ways we give medications as well as the process to safely administer medications in the field. Let's get started.
The enteral route refers to medications given through some portion of the gastrointestinal tract. This includes oral administration, delivery through a feeding tube, or rectal administration. Because the medication must pass through the GI system, absorption is slower compared to parenteral routes. On average, onset occurs in about 30 to 90 minutes, depending on the drug, formulation, and patient factors. A key concept here is first-pass metabolism. No matter which enteral route is used, the liver will always take some of the medication first, reducing the amount that ultimately reaches systemic circulation. This is an important consideration when thinking about dosing, onset, and overall effectiveness. Any route other than the gastrointestinal tract is considered a non-enteral route. This includes intravenous, intraosseous, intramuscular, inhaled, and percutaneous routes. Percutaneous routes involve absorption through the skin or mucous membranes. Common examples include sublingual, buccal, and intranasal administration. Sublingual medications are placed under the tongue, such as nitroglycerin or orally disintegrating Zofran. Buccal medications are placed between the cheek and the gum, with oral glucose being a common example. Both sublingual and buccal routes require a patent and protected airway to be used safely. Intranasal medications are delivered using an atomizer device. Only certain drugs are effective intranasally due to their molecular structure. Common examples include naloxone, fentanyl, morphine, midazolam, glucagon, and ketorolac, depending on local protocol.
Inhaled medications are primarily used in the treatment of respiratory emergencies because they deliver medication directly to the affected tissues in the lungs. Common examples include bronchodilators, such as albuterol and the anticholinergic ipratropium. There are several ways to nebulize medications. A small volume nebulizer can be used on a spontaneously breathing patient. Medications can also be delivered through CPAP with a nebulizer attachment or through a BVM with a nebulizer attachment for patients requiring assisted ventilation. Endotracheal tube administration is a last resort route reserved for situations where other vascular access is unobtainable or significantly delayed. Absorption is less predictable, so medication doses often need to be increased to 2 to 2.5 times the IV dose. Medications that can be given through the endotracheal tube are remembered using the mnemonic NAVAL: naloxone, atropine, vasopressin, epinephrine, and lidocaine. Medication administration starts with understanding the equipment. Syringes come in a wide range of sizes, typically from 1 milliliter up to 60 milliliters or more, with the 3 milliliter syringe being the most commonly used in EMS. Syringe size is chosen based on the amount of medication you intend to administer. Pay close attention to the markings. 1 milliliter syringes are marked in hundredths, 3 milliliter syringes in tenths, 5, 6, and 12 milliliter syringes in 0.2 milliliter increments, and 20 milliliter syringes in 1 milliliter increments. Needles are made up of the hub, which connects to the syringe, the shaft, and the bevel at the slanted tip. Never touch the shaft or bevel to maintain sterility. Needles are measured in gauges, where a smaller gauge number means a larger diameter. Most needles are covered with a protective cap and may include a safety mechanism to prevent needle stick injuries. Ampules are breakable, sterile glass containers. The top is snapped off using gauze, and medication is withdrawn using a filter needle to prevent glass particles from entering the syringe. Vials are glass bottles with a rubber stopper and may be single dose or multi-dose. Always clean the stopper with an alcohol wipe before access and only draw up what you intend to administer. Some medications require reconstitution, such as Solumedrol or glucagon, which must be mixed with diluent before use. Finally, pre-filled syringes, such as epinephrine, calcium, or sodium bicarbonate, are designed for speed and convenience, especially during emergencies. In the lab, we'll review the step-by-step process for safely drawing medication from a vial. A subcutaneous injection delivers medication between the dermis and the muscle into the subcutaneous tissue. This route uses a small needle, typically 24 to 26 gauge, and only small volumes of medication are administered, generally 2 milliliters or less in adults. Common injection sites include the forearms and the abdomen, where there is adequate subcutaneous tissue for absorption. Subcutaneous injections are commonly used for medications such as insulin, which many diabetic patients self-administer daily, and for procedures like a tuberculosis skin test. An intramuscular, or IM, injection delivers medication directly into the muscle, allowing for faster absorption than the subcutaneous route. Muscles are highly vascular, which improves medication uptake. IM injections require a 21 to 23 gauge needle that is typically 1 to 2 inches long enough to reach the muscle layer. Never use your draw needle to administer an IM injection. Always switch to a clean administration needle. The maximum volume that can be given depends on the injection site, and proper landmarking is critical to avoid nerve injury. The anterior deltoid is commonly used in adults and has a maximum volume of about 2 milliliters. The injection site is located in the lateral triangle, roughly 1.5 to 2 inches below the acromion process. The thigh, specifically the vastus lateralis, can accommodate larger volumes, up to 5 milliliters in adults and less in children. It is the preferred IM site for infants. Landmarking is done by placing one hand below the greater trochanter and the other above the knee. The area between your hands is the injection site. The hip can be accessed using either the dorsogluteal or ventrogluteal approach. The dorsogluteal site is in the upper outer quadrant of the buttock and should not be used in patients under 2 years old due to the risk of sciatic nerve injury. Positioning the patient with knees flexed and toes rotated inward helps relax the muscle. The ventrogluteal site is the preferred hip site for children and is identified by placing your hand on the greater trochanter, pointing the index finger toward the anterior superior iliac spine, and spreading the remaining fingers along the iliac crest. The injection is given in the center of the V formed by your fingers. The Z-track technique is used during intramuscular injections to keep medication deep within the muscle and prevent it from leaking back into the subcutaneous tissue. Begin with standard precautions and verify the patient's rights. When possible, explain the procedure to the patient. Identify the correct anatomical landmarks and clean the site with an alcohol wipe. Next, displace the skin laterally by about 1 inch and hold it in place. Insert the needle with a dart-like motion at a 90-degree angle, then inject the medication. Once the medication is delivered, remove the needle and release the skin. This creates a zigzag path that seals the medication in the muscle. Dispose of the sharp properly, apply gentle pressure to the injection site, and finish by evaluating the patient and documenting the procedure. When administering IV medications and fluids, understanding drip sets and flow control is critical. Microdrip chambers deliver 60 drops per milliliter and are commonly used when infusing medications mixed in fluid, such as epinephrine drips, tranexamic acid, or amiodarone maintenance infusions. With microdrip tubing, the number of drops per minute equals the infusion rate in milliliters per hour. For example, 30 drops per minute equals 30 milliliters per hour. Macrodrip tubing delivers larger drops, most commonly 10 or 15 drops per milliliter, and is typically used for fluid resuscitation rather than precise medication infusions. Volume control chambers are used to limit the amount of fluid delivered to the patient. This is especially important in pediatrics, where excessive fluid administration can have serious consequences. The provider sets a specific volume into the chamber attached to the IV bag, allowing controlled delivery. Y-tubing may also be present, providing an additional Luer lock access port. Finally, infusion pumps provide the most accurate method of fluid and medication delivery. Without a pump, infusions rely on gravity, meaning flow rate can change based on bag height and patient position. When a pump is not available, the infusion rate must be checked and validated frequently to ensure safe administration. When administering IV fluid boluses, dosing is based on patient age and size. For adults, the standard bolus dose is 30 milliliters per kilogram with a maximum of 2 liters. It's important to remember that you do not always need to give the full maximum. Fluid administration should be guided by the patient's condition and response to treatment. For pediatric patients, generally defined as ages 1 through about 12 or before signs of puberty, the bolus dose is 20 milliliters per kilogram. For neonates, defined as the first month of life, fluid boluses are smaller, typically 10 milliliters per kilogram. A KVO rate, or keep vein open rate, is usually set at 30 to 50 drops per minute and is used to maintain IV patency when fluids are not being aggressively administered.
When preparing an IV medication infusion, the medication is added to the injection port on the IV fluid bag. Always label the infusion with the medication name, concentration, date, and time. The primary line is the main IV fluid, most commonly an isotonic solution such as normal saline, because it mixes well with most medications. Certain compatibility rules are critical. Epinephrine is not mixed with lactated ringers, and blood products are administered with normal saline only. A secondary or piggyback line connects to the Y-site adapter of the primary line. The smaller secondary bag is hung higher than the primary fluid, allowing it to infuse first using gravity. To administer a piggyback medication, clamp the primary line above the secondary port, set the secondary infusion rate, and allow it to infuse completely. Once finished, remove the piggyback and unclamp the primary line to resume the main infusion. Pay close attention to drug concentrations. For example, mixing 1 milligram of epinephrine in 500 milliliters of fluid results in a concentration of 2 micrograms per milliliter. Understanding these concentrations is essential for safe and accurate medication administration.
Intraosseous, or IO, access involves placing a needle into the intramedullary space of the bone. This route is especially useful in critically ill or shock patients when venous access is difficult or delayed. The intramedullary space is highly vascular and provides a direct route to central circulation, which is why IO access is effective for rapid medication and fluid delivery. During shock, peripheral vessels constrict, making IV access difficult or even impossible. Indications for IO access include situations where IV attempts are unsuccessful or would take too long, and the patient needs emergent medications, such as during cardiac arrest. Contraindications include situations where IV access can be readily obtained, or when the target bone is fractured, as this increases the risk of infiltration. Although medications reach the circulation quickly, fluids may not infuse as rapidly through an IO and often require a pressure infuser. IO access can be used in conscious patients, but it can be painful, so a lidocaine bolus may be needed for pain control. When using pressure infusers, monitor closely, as excessive pressure can increase the risk of infiltration or embolic complications. Intraosseous access can be established at several anatomical locations. Common sites include the proximal humerus, proximal tibia, distal femur, and distal tibia. In practice, the proximal humerus and proximal tibia are the most frequently used sites, with the humeral site being especially effective in adults due to rapid flow into central circulation. IO access can be achieved using manually inserted needles or a powered EZ-IO drill. Manual IO devices were originally designed for pediatric patients and are still commonly used in smaller children. These are inserted using a twisting, screw-like motion until the needle enters the bone. The solid stylet is then removed, leaving a hollow metal catheter that connects to standard IV tubing. The EZ-IO drill uses color-coded needles based on patient size and tissue depth. The 15 millimeter red needle is used for patients weighing 3 to 40 kilograms. The 25 millimeter blue needle is appropriate for patients over 3 kilograms, and the 45 millimeter yellow needle is used for patients over 40 kilograms and is the preferred size for humeral placement. When selecting a needle, remember that the amount of tissue overlying the bone is just as important as patient weight. Proper site identification and technique are critical, and we will review anatomical landmarks and the step-by-step IO insertion process in class. The proximal humerus is an acceptable and commonly used IO site in adult patients, especially when rapid access is needed. The insertion site is located 1 to 2 centimeters above the surgical neck of the humerus on the lateral aspect of the humeral head. Proper positioning is critical for success. The patient's arm should be bent or straight and rotated outward to move the biceps tendon out of the insertion path. When inserting the needle, aim at approximately a 45-degree angle toward the opposite hip. Correct landmarking, positioning, and needle direction help ensure proper placement and reduce the risk of complications. The proximal tibia is a commonly used IO access site, particularly in pediatric patients, but also acceptable in adults. To locate the site, identify the tibial tuberosity, which is the bony prominence on the anterior medial aspect of the tibia just below the patella. The insertion point is located 1 to 2 centimeters, or about 2 finger breadths, below the tibial tuberosity. Accurate landmarking is essential to ensure proper needle placement and effective intraosseous access. The distal femur is an intraosseous access site primarily used in pediatric patients when the proximal tibia is not feasible. For proper positioning, the leg should be kept straight to prevent knee movement during insertion. The insertion site is located approximately 1 centimeter above the patella and 1 to 2 centimeters medial to midline.
The distal tibia is an intraosseous access site that can be used in adult patients. To identify the site, locate the anterior medial aspect of the distal tibia. The insertion point is approximately 2 centimeters proximal to the medial malleolus, which is the bony prominence on the medial side of the ankle. As with all IO placements, accurate landmarking and stabilization of the extremity are key to successful insertion and safe medication or fluid administration.
Before IO placement, assemble and prepare all equipment. This includes the IO needle, a 10 milliliter flush, extension set, stabilizer or bulky dressing, tape, alcohol prep, appropriate PPE, and a sharps container. Identify the appropriate insertion site with the proximal humerus commonly preferred in adults and thoroughly clean the site. Position the needle against the skin and advance it straight in at a 90-degree angle until it contacts the bone. At this point, at least one black marker line should remain visible outside the skin, confirming appropriate needle length. Activate the drill and advance the needle into the bone until a distinct pop is felt, indicating entry into the medullary space. Remove the stylet and immediately place it in the sharps container. If a stabilizer is used, apply it before connecting IV tubing. Attempt to aspirate marrow, then flush the line to confirm patency. In conscious patients, IO flushing can be painful. A lidocaine bolus of 10 to 20 milligrams, up to a maximum of 60 milligrams, may be administered prior to flushing to improve patient comfort.
The purpose of intravenous access is to administer fluids and medications through continuous infusion, intermittent infusion, or IV push. IV access is also the required route for blood product administration. Additional uses may include hemodynamic monitoring or therapies such as dialysis. The most common device used for IV access is the over-the-needle catheter. This catheter has a plastic sheath over a metal needle. Once the vein is cannulated, the needle is removed and the plastic catheter remains in the vein, allowing the IV to stay patent and reducing the risk of vein damage during patient movement. In contrast, butterfly needles are primarily used for blood draws. They are made entirely of metal and do not contain a plastic catheter, which is why they are removed immediately after use and are not intended for ongoing IV therapy.
Veins are typically more superficial vessels that return blood back to the heart. The walls of veins are made up of 3 layers referred to as tunics. The tunica intima is the innermost layer and consists of a single layer of epithelial cells, allowing blood to flow with minimal resistance. The tunica media contains smooth muscle, which is innervated by the autonomic nervous system. Smaller veins contain less smooth muscle than larger vessels. The tunica adventitia is the outer connective tissue layer that helps anchor the vessel and also contains small arteries and veins that supply the vessel wall. Venous blood return relies on several mechanisms, including skeletal muscle contraction, respiratory movements, and gravity. To assist with this process, veins contain one-way valves that prevent blood from flowing backward. These valves may sometimes be identified by a slight bulge in the vein just above the valve, though they are not always visible.
Digital veins are located on the medial and lateral sides of the fingers. These veins are fragile and blow easily, so they are generally avoided for IV access. Metacarpal veins are formed as the digital veins merge on the dorsum of the hand. In older patients, decreased connective tissue can make these veins poorly anchored, increasing the risk of infiltration and making IV access more difficult. The cephalic vein runs along the radial or thumb side aspect of the wrist and forearm. Use caution in this area as the radial artery and nearby nerves are also present. The basilic vein is located on the medial aspect of the arm and is often overlooked. When cannulating peripheral veins, always advance the catheter toward the heart to ensure proper placement and flow. The basilic and cephalic veins run the length of the entire arm and are connected by branching veins as they travel proximally. One of the most well-known connecting veins is the median cubital vein, commonly referred to as the antecubital vein. This vein is frequently used for IV access due to its size and ease of identification. In contrast, veins in the lower extremities are generally avoided for peripheral IV access because they carry a higher risk of complications, particularly infection and thrombosis. These sites should be used only when absolutely necessary and when upper extremity access is not available.
When selecting a vein for IV access, go by feel, not by sight. A good vein often isn't the most visible one. It should feel soft, elastic, and bouncy under your fingers. Several techniques can help veins become more prominent. Warmth is one of the most effective, as cold skin causes vasoconstriction. A warm compress works well. Light tapping over the area may help, but excessive pressure can trigger a sympathetic response and actually cause vasoconstriction. Allowing the arm to hang down increases venous pressure and can improve vein filling. Applying a venous tourniquet is standard practice. A blood pressure cuff inflated to about 10 millimeters of mercury below the systolic pressure can also function as a venous tourniquet and is useful for patients with latex allergies. When choosing a site, look for straight veins without bifurcations and start distally so you preserve more proximal sites if needed. Avoid areas over joints or near trauma or injury, as movement and swelling increase the risk of infiltration and IV failure.
Before attempting IV access, ensure all necessary equipment is prepared and within reach. This includes appropriate personal protective equipment, skin cleansing materials, and a tourniquet. You'll need the correct IV catheter, an IV infusion set, or PRN, and a 10 milliliter saline flush to confirm patency. Dressing materials are also essential. Use a transparent occlusive, dressing with tape to secure the catheter and protect the site. Occlusive dressings are especially important to prevent air from entering the system, which is critical when placing IVs in sites such as the external jugular vein. Successful IV placement starts with proper positioning. For the patient, rest the selected body part in a comfortable, supported position and adjust it to give you the best possible view and access to the insertion site. For you, as the provider, ensure you have good body mechanics and are positioned comfortably. Being stable and relaxed improves control and accuracy during insertion. A simple but important tip: if you're comfortable before you insert, your chances of success are significantly higher. Once you're ready to start the IV, begin by identifying and preparing the insertion site. Apply PPE and place a venous tourniquet, positioning it so it can be released easily with a single quick tug. Take time to locate a suitable vein using palpation, not just visualization. Set up your equipment before insertion. This includes preparing the IV catheter, attaching the PRN adapter if used, flushing it, and making sure tape and a transparent dressing are within easy reach. Before insertion, slightly rotate the cannula around the needle to ensure it moves freely. Do not slide it up and down over the needle. Clean the site thoroughly and allow the cleansing solution to dry completely. Once cleaned, do not touch the site again prior to insertion to maintain sterility. To insert the IV catheter, begin by applying distal traction on the skin with your non-dominant hand. This helps stabilize the vein and prevents it from rolling. Hold the angiocath between your thumb and index finger, keeping the bevel facing up. Let the patient know you are about to stick. Insert the needle at a shallow angle, roughly 10 to 30 degrees, entering the skin about 1 to 2 centimeters below where you intend to access the vein. As the needle tip enters the vein, you'll see a flash of blood in the flash chamber, and you may feel a subtle pop. Once you see flash, stop advancing, lower your angle to better align with the vein, and advance the needle another 1 to 2 millimeters. Hold the needle steady and slide the catheter off the needle and into the vein. After the catheter is fully advanced, occlude the vein above the insertion site, remove the needle, and immediately place it in a sharps container. Proper technique and controlled movements reduce the risk of blowing the vein or puncturing through the back wall.
Once the catheter is in place, release the tourniquet and begin the infusion process. Attach the PRN adapter, then attempt to aspirate for blood return and slowly flush 10 milliliters of saline to confirm patency and proper placement. After confirming the IV is functioning, dress the site by applying a clear occlusive dressing. Use tape to secure the PRN adapter to the patient's skin, helping prevent movement or dislodgement. Finally, clean any blood from around the site and reassess for signs of infiltration or patient discomfort. If problems occur during IV insertion, there are several common signs to recognize. If no flash appears, slowly withdraw the needle. You may have passed through the back wall of the vein. If a flash appears during withdrawal, proceed with normal advancement. If there is still no flash, bring the needle almost back to the skin surface and adjust your angle or direction. The needle should never be removed completely and reinserted through the skin. If local swelling occurs, stop the attempt immediately and apply pressure. This indicates infiltration, and any future attempts should be made proximal to that site. If you encounter resistance during insertion, you may be at a venous valve. Try raising the patient's arm. If resistance persists, the catheter is likely not in the vein. Stop advancing and withdraw slowly. If flash appears, you may still be able to salvage the line. Remember, IV success improves with practice. However, after 2 unsuccessful attempts, allow another provider to try to minimize patient discomfort and complications.
There are several common mistakes to avoid during IV placement. Never forget to clean the site. Proper skin antisepsis is critical to prevent infection. Do not leave the tourniquet on after the procedure is complete, as this can cause venous congestion and compromise the IV. Never remove the needle from the skin and then reinsert it during an attempt, as this increases the risk of infection and vessel damage. Likewise, do not slide the catheter up and down over the needle, which can shear the catheter or damage the vein. Avoiding these errors improves IV success, reduces complications, and keeps the procedure safe for both the patient and the provider.
Infiltration occurs when IV fluid escapes into the surrounding tissue, causing localized swelling or edema. Extravasation is more severe and involves the leakage of an irritating medication into surrounding tissue, which can lead to blistering and tissue injury. If either infiltration or extravasation is suspected, stop the infusion immediately, discontinue the IV at that site, and reestablish access at a different location. Common causes include catheter dislodgement, puncture of the distal vein wall during insertion, a poorly secured catheter, or the infusion of irritating medications, such as promethazine. Catheter occlusion occurs when a blood clot forms inside the IV catheter. Never attempt to forcefully flush an occluded IV, as this can dislodge the clot or damage the vein. Venous spasm is often caused by irritating solutions, such as dextrose containing fluids, and presents as severe pain radiating up the extremity from the IV site. Management includes slowing or temporarily stopping the infusion until the spasm and pain resolve. Phlebitis and thrombophlebitis involve inflammation of a vein, with thrombophlebitis specifically referring to inflammation that leads to blood clot formation. These conditions typically present with pain and tenderness along the affected vein, and patients may describe an aching or burning sensation at or along the IV site. Unlike infiltration, symptoms often develop several hours after IV insertion rather than immediately. If phlebitis or thrombophlebitis is suspected, the appropriate action is to discontinue the IV at that site and establish access at a different location as needed. Additional IV complications require prompt recognition and action. A hematoma often occurs when the needle punctures the back wall of the vein or when pressure is not held after removal. Signs include rapid swelling, bruising, pain, and inability to flush. If this occurs, stop the attempt and apply firm pressure. Nerve, tendon, or ligament injury is minimized by avoiding sites near joints. If the patient experiences sudden, severe shooting pain, tingling, numbness, or loss of movement, stop immediately and select a different site. An arterial puncture may be identified by pulsatile flow or bright red blood. Stop the attempt and apply pressure. An air embolism can occur if air enters the bloodstream, most concerning with large central veins such as the external jugular, or if tubing runs dry. If suspected, place the patient on their left side and administer oxygen. This helps trap the air in the right ventricle. Catheter shear is a serious complication where a fragment can break off and act as an embolus. If suspected, manage similarly by placing the patient in a left lateral position and seek definitive care. Finally, systemic infection is a preventable complication. A septic technique is paramount during IV insertion and maintenance to protect patient safety. Under PAS 8-state protocol, external jugular IV access may be used in a critically injured patient age 8 or older who requires IV fluids or medications when an extremity vein cannot be obtained. This procedure carries higher risk, so strict attention to technique is critical. Always palpate for a pulse first to avoid arterial cannulation, and insert the catheter toward the heart. Position the patient supine with the head down to distend the jugular vein and turn the head away from the insertion side. This improves visualization and access. Key risks include inadvertent carotid artery cannulation and air embolism, as patients can entrain a significant volume of air through the EJ. Contraindications include inability to lie flat, active vomiting, agitation, spinal trauma, circumferential neck burns, infection at the site, anatomical obstruction, or AEVP shunt on the insertion side. During insertion, occlude the jugular vein distal to the site with your finger to help engorge the vein. Never blind stick. Align the catheter with the direction of venous flow and insert midway between the angle of the jaw and the midclavicular line. If at any point landmarks are unclear or risk is high, do not proceed. Choose an alternate access method. To wrap up, IV access is a fundamental paramedic skill that directly impacts patient outcomes. Success comes from good preparation, proper anatomy, clean technique, and sound decision-making. Remember, slow down, use aseptic technique, choose the right site for the right patient, and recognize complications early. If something doesn't feel right, stop and reassess. There is no penalty for asking for help or choosing a different access route. With practice, your confidence and success rate will improve. Focus on patient safety first. Document clearly and always work within your protocols. This skill will be used on nearly every call. Master it, respect it, and use it wisely.